Good morning, everyone. I'm so pleased to be here and join the meeting. I'm among old friends. You may hear me a little bit faint today. Good morning, good morning. You can hear me a little bit faint today. We had a technical issue, so I'm joining with the iPad. You won't have the extreme beauty delivered through my camera, but that will allow you to focus on the most important part of the morning. So what we're going to do today, so we're going to start with a journey. We're going to look at segmentectomy, and that is going to be introduced by my friend and ex-colleague, Tim Batchelor. He is well known in UK, so I suspect his introduction is only for the people who are joining from Europe or the rest of the world. He's been pioneer in enhanced recovery in thoracic surgery. He is one of the authors of the international guidelines for enhanced recovery in thoracic surgery. He's been one of the forces behind the Violet trial that we are all looking forward to see published in his full results, comparing VATS lobectomy versus open lobectomies. And then we are going to go into a little bit of the details of the segmentectomy, and that will trigger some of the issues as surgeons we have been facing especially when either when explaining segmentectomies to juniors or trying to train them, or when ourselves trying to approach the difficult segment that are usually the less frequent and the one with most variation in terms of bronchial and viral anatomy. And so we have the opportunity of being Prof. Soler. Prof. Soler is a digestive and endocrine surgeon. He is professor at the University of Strasbourg. He has been a leading force behind the R&D department at ERCAD. And he's here to present visible patients. That is one of his child. And finally, we will have time for a few questions. I was planning to present how I will use visible patient for planning. The technology has failed me today, so you know that where I live, you know how to contact me, so that there is going to be space for me to do that directly one-to-one or one-to-few in the next future. And now, without wasting too much time, Tim, audience is yours.
Thank you very much, Gianluca. Let me just get my screen up for you. And hopefully you can see that.
Perfect.
Yeah. So yes, thanks, Gianluca. Welcome, everyone. My name is Tim Batchelor from Bristol. I'm going to give a brief talk about segmentectomy and really about the journey that segmentectomy as an operation has gone on over the last 7 or 8 decades or so. And I guess before we go to that, we have to ask ourselves, why are we doing a segmentectomy? And Alan Sehoe put this succinctly the other day, and it's to preserve lung function. That's why we're doing it at the end of the day. And yes, we might be trying to reduce complications or length of stay, but ultimately it's to preserve lung function. And that's true whether you're doing an intentional segmentectomy or a compromised segmentectomy. So I'll just briefly talk about what intentional and compromised is. And this comes from Alex Brunelli. So an intentional segmentectomy is someone whom you're going to do a segmentectomy on, but they are actually functionally fit for a lobectomy. And there's growing acceptance that we should be doing this for ground glass nodules, but there's renewed interest, particularly for the part solid and solid nodules, those less than 2 centimeters. So what's a compromised segmentectomy? So it can be compromised because of function. This patient here is because of poor lung function, or maybe comorbidities which preclude doing a lobectomy. It could be compromised for diagnostic reasons. So in other words, you have a nodule. It might be a lung cancer, but very unlikely. The nodule's too central for a wedge, so we have to perform a diagnostic segmentectomy. Or maybe we're compromised because we've got multiple tumours. We've got a number of very small tumours which are going to require lung resection, as in this patient here. Or maybe they've had a previous lung resection. You try to spare as much lung parenchyma as possible. But at the same time as we're thinking about doing a segmentectomy, we should think about why we shouldn't be doing a segmentectomy, or rather, there are opinions around the world as to why we shouldn't be doing segmentectomy. And the one is oncological outcomes. Are the oncological outcomes the same because we shouldn't be compromising? And we will talk about this. What about lung function? We've said at the beginning, we're trying to preserve lung function. That's the whole point of a segmentectomy. But are there actual differences between segmentectomy and lobectomy? And then there are technical considerations pertinent to this presentation. Preoperative planning. Which segment is the nodule actually in? I'm sure you've all looked at a CT scan and been scratching your head as to which segment the nodule is in. And what about the bronchovascular anatomy? It varies greatly from patient to patient. How do we get a hold of that just by looking at a normal CT scan? Sometimes it can be difficult to find the nodule intraoperatively. And then what about the technique? VATS segmentectomy is a more difficult operation than VATS lobectomy, and it's more difficult VATS than open as well. What about vessel control? Staplers are often too big for some of these vessels. And what about division of the parenchyma? That can be tough, knowing exactly where to put your staples, because some of the techniques we have are a little primitive in terms of defining parenchymal boundaries. So let's start by going on a bit of a journey then. This is a journey through the history of segmentectomy, trying to bring us up to the present day. So the first segment was actually described by Churchill and Belsey, two famous thoracic surgeons. What they called a segmental pneumonectomy was actually a lingulectomy performed for bronchiectasis back in 1939. And then the operation became more popular as surgery for lung cancer became more popular. And there are a number of case series, including this large one from Gensic, demonstrating a 5-year survival rate of 56%, but a fairly high local recurrence rate of 10% for segmentectomy operations. And so things were going along nicely, but it was felt that there should be a randomized controlled trial, and we're all familiar with the Ginsberg paper from the lung cancer study group, which randomized patients into lobectomy or segment or wedge resection for their early stage lung cancer, and looking at survival out at 5 years. There wasn't a significant difference between survival between the lobectomy and the limited group, but there was a significant difference in terms of local recurrence. So in other words, you were more likely to have a local recurrence if you had an operation other than a lobectomy. And this, it wasn't quite the death knell for segmentectomy, but it certainly made the operation a lot less popular. But then come the 21st century, people began to get more and more interested in it. And this is one of the first meta-analyses looking at 14 articles. They noted that there was a lot of heterogeneity. And what they showed was that in terms of 1, 3, and 5 year survival, there was no difference in survival between lobectomy and segmentectomy, although maybe a trend towards a better survival in the lobectomy group. So not only do we have meta-analyses, but some quite large case series as well. This is a retrospective analysis looking at 577 lobectomies, 207 sublobar resections. And on the face of it, the long-term survival seems to be worse for sublobar resections compared to lobectomy. But of course, you can manipulate anything with statistics. And so by controlling for lymph nodes resected and stage 1B disease and what have you, the authors managed to get equivalent survival curves for both the sublobar group and the lobectomy group. Landreneau is one of the biggest proponents of segmentectomy in the US. So he went one step further from his case series and looked at propensity matching. 300 patients or so in each group all had systematic lymph node sampling, and over half the patients had VATs. What did he find? Well, in terms of recurrence, no difference in recurrence in the segmentectomy and lobectomy groups, and similarly no difference in survival either. Another big meta-analysis coming just after that, so lots of meta-analyses, 21,000 patients. What did they find? Lobectomy was better than segmentectomy in terms of survival, and wedge was not inferior to segmentectomy. So a slightly different message from some of the other studies we've looked at. And then to look at something slightly different, ground glass nodules instead of solid nodules. Again, big study, nearly 2,000 patients. And they found that overall survival in the segmentectomy group, in those who could tolerate lobectomy, so in other words, this is an intentional segmentectomy, overall survival was very good at 94%, recurrence-free survival at 91%. And they concluded that in ground glass nodules, patients should be considered for limited resection. So what can we make of that quick canter through the evidence up to 2015? Well, it's a bit of a mixed bag, really, isn't it? And I guess you could choose the evidence that fits with your beliefs. So if you're a lobectomist, then that's fine. If you're a segmentectomist, then that's fine as well. You could just choose the study which best fits what you believe in. But the BTS guidelines, BTS came up with their nodule guidelines, and they tried to sort of distill the evidence into some recommendations, and they made a good stab at it. They said you should consider anatomical segmentectomy where preservation of functioning lung tissue may reduce the operative risk and improve physiological outcome. So in other words, this is a compromised segmentectomy. Consider a diagnostic anatomical segmentectomy for nodules less than 2 centimeters. So again, a compromised segmentectomy. Or consider sublobar resection for pure ground glass nodules owing to their excellent long-term prognosis. So this is an intentional segmentectomy, but in this very specific ground glass nodule group. Okay, so what's happened since then? Well, maybe there is a little bit more clarity about what we are meant to be doing. So this is a nice paper from Cow looking at a large database, the SEER database, nearly 17,000 patients. And they divided the T1 tumours into tumours less than 1 centimetre, tumours 1 to 2 centimetres, and tumours 2 to 3 centimetres. And they plotted survival against what operation you'd had. So blue is lobectomy, green is segmentectomy, and yellow is reg. So for very small tumours, there appeared to be no difference in long-term survival depending on the operation that you did. When you got to 1 to 2 centimetres, then wedge resection appears to be inferior, but segmentectomy and lobectomy appear to be the same in terms of lung cancer survival. And then once you get to larger tumours, so in other words, those greater than 2 centimetres, then lobectomy is clearly superior to segmentectomy or wedge resection in terms of long-term survival. Wow, so there's quite a lot going on, isn't there? So is it time to reconsider our attitudes to segmentectomy? Because after all, it's over 25 years since the Ginsberg paper came out. We seemingly have good outcomes in some of the non-randomized studies for early stage lung cancer. If you pick the right studies, you have to remember that back in at the time of the Ginsberg paper, they didn't have CT scan, they didn't have PET scan, and their follow-up was and diagnosis was all based on chest X-ray. We appear to have a new disease entity that's emerged over the last couple of decades with ground glass nodules and part solid nodules. They behave differently, and maybe we should be approaching these things differently. And of course, screening programs. Screening programs are throwing up a whole load of tiny nodules that we need to deal with. So surely time for a randomized controlled trial. And of course, you know about the 2 large randomized controlled trials that are ongoing, and indeed JCOG has just reported, and we'll talk very briefly about this. So the JCOG 0802 study from Japan, non-inferiority study of segmentectomy versus lobectomy. in tumours less than 2 centimetres. So this is intentional segmentectomy, so those that can tolerate a lobectomy. Large study, 1,100 patients. CALGB is its equivalent in North America, almost identical protocol, but including wedge resections, and actually around wedge resections make up about half of this group. So JCOG, they published their initial results, their safety results in 2009 in JTCVS, and showed no difference in mortality between the segmentectomy and lobectomy group. So maybe that's slightly unusual, but they showed no difference because there was no mortality. Complication rates were similar between the two groups at around 26, 27%. But what they did find that you were more likely to have an air leak in the segmentectomy group. And if it was a complex segmentectomy, more likely to have an air leak again. So last weekend, you'll have seen the JCOG results presented at AATS, and I think David Waller is going to talk in a bit more detail about it today at the Society meeting as well. And they presented their 5-year results. And their 5-year results on face value are quite remarkable, because overall survival for lobectomy was 91%, but for segmentectomy was 94%, and this was significantly better. Bearing in mind, this is a non-inferiority study. So it's shown something that the authors were not expecting to see. But in the, what we did see in the segmentectomy group was that there was greater local recurrence, 10% versus 5% in the lobectomy group. Although disease-free survival was the same, or recurrence-free survival was the same in both groups. And lung function was better preserved in the segmentectomy group and the lobectomy group. So this was significantly different, but you have to ask, is a 3.5% difference actually of any clinical meaningful value? Anyway, the authors concluded from this that segmentectomy should essentially be the standard procedure instead of lobectomy for small peripheral non-small cell lung cancer. So that's quite a bold statement, isn't it? And I looked at that, and my initial thoughts were, yes, that's right. But then reflecting on the results, I'm not quite sure what to make of it. As someone who supports segmentectomy, you would point to the better overall survival and the better lung function. For someone who would support lobectomy more, then you would point to the better local recurrence rate with lobectomy, the equivalent recurrent-free survival, and actually point to the fact that there's probably no clinically meaningful difference between preservation of lung function. So I think we need to wait for these results to be peer-reviewed and to be assimilated into international guidelines. And we also need to think about the patient and what the patient wants. So just quickly, before we finish, talking about preservation of lung function, because ultimately this is why we're doing a segmentectomy. This is a nice paper trying to summarize all the evidence so far. So this is lung function after lung resection. Red line is baseline, and the solid line is the average for the segmentectomy papers, and the dotted line for the lobectomy papers. So there is a significant difference in FEV1 between the two groups, but it's fairly modest. And again, you have to ask whether the difference is of any clinically meaningful benefit. On top of that, we need to look at the emerging literature as well. So there's some evidence soon to be published which suggests that if you take out more than half a lobe with your segmentectomy, then you don't change the outcomes at all. There is no functional benefit. And so maybe we shouldn't be doing things like lower lobe basal segmentectomies. Briefly then, going back to these technical considerations, which we talked about at the beginning. Preoperative planning, which segments, when you're looking at your CT scan, which segments it in? What about the variability in bronchovascular anatomy? This is what Luc Solé is going to talk about shortly. This is where visible patient comes in, and I hope you'll be impressed with this technology. Intraoperative localization, This was discussed by Kelvin Lau at the meeting on Sunday, using various hybrid techniques now to localize tumors. So the technology is beginning to enable this. And what about intraoperative technique? We're getting more expert at VATS. We should be doing VATS because it's a better approach than the open. And if you do an open segmentectomy, that's likely to negate any potential benefits of segmentectomy. What about vessel control? Well, we have energy and other things like this now to enable us to do this VATS. So we don't necessarily need to worry about the size of our staples. And what about division of parenchyma? Well, more and more of us have access to intracyanine green, intravenous intracyanine green, and that appears to be the way forward in defining the lung parenchyma. Okay, then. So we've been on a bit of a journey with segmentectomy, haven't we? If we look back to 1939, Churchill and Bels's first description of their segmental pneumonectomy, then the popularization of the operation in the 1970s, and then in 1995, the lung cancer study group, which essentially stopped people from doing segmentectomy for a short period of time. But in this century, there's been renewed interest, particularly for the T1A and T1B and 0 patients. And then if we look at the other things that are happening right now, we've got screening, we've got the randomized controlled trials for intentional segmentectomy, and then we've got technology, which is enabling us to do VATS segmentectomy. What are the recommendations going to be? I'm not quite sure, but I think as technology enables us to do segmentectomy, and as the evidence becomes more secure, then it's likely that segmentectomy will become a popular option for our patients with early stage disease. Thank you very much.
Thank you very much for this presentation of segmentectomy. So I followed your presentation immediately in order to save time and to show you as much as I can during the presentation. So what I will present you is a technology named Visible Patient. Visible Patient is an online medical image analysis laboratory. It works like a lab, and the idea is the following one. When you have a medical image, you have a set of slices, and it's frequently complex to understand from such gray levels and from such slices the patient in 3D on the precise vascular anatomy, bronchus anatomy. So what is the solution we propose? Really simple to explain, like a house map. We will switch the CT scan, the slices in a 3D map. It's easy to explain like this, and it is exactly what we can expect because, of course, human eyes and brain are not adapted to see gray levels, and they are not adapted to see in 2D. Our brain, our eyes have been developed to see in color and to see in 3D. And this is one of the reasons why we have such difficulty to understand what is precisely the anatomy in 3D of the patient. And for segmentectomy, it is a major issue, as you will see. You have speak about segmentectomy. I will speak you about subsegmentectomy, as you will see, because in reality, segment, like for liver, you know, I work in a digestive team. Like for liver, it is an anatomical vision that is based on the past way to work with patient freeze and cut in slice, but not with medical images that can provide amazing benefit. So what is the benefit we can propose? Is to do, like, as I said, your lab. When you want a blood analysis, you don't do it by yourself. So we develop the same thing for Visible Patient. We have created an online lab. From the CT scan or the MRI, we receive from the surgeon onto a secure platform system managed by Johnson & Johnson. We receive it. We do the analysis in our lab, Visible Patient. It is double-checked by medical expert. Each model is double-checked, so control before to be pushed back, and then push back onto the secure system. What is important to notice here is the fact that the system does not go inside the hospital push the image outside. It's really important for the security of the hospital. In the same way, the surgeon downloads the image only when he needs, but it's not a push from our system to the hospital. So you have a really good security for your hospital with such a system. And the medical images that are pushed out are unidentified. We have no name of the patient with this system, allowing to secure also the data transfer. So you see, it has been think about the security of patient data. We can do such modeling for any part of the human body. Today, I will focus on the thorax, but it's important to notice that if you need modeling for other areas of the body, it is possible, of course. So, visible patient is different for several reasons. In France, for instance, you see, it is covered by more private insurance that covers the price of the modeling. It is distributed, as you know now, by Ethicon worldwide, and you see that from March, we have 11 new countries that have access. And this system gives an access through a software that is free of charge. It's a medical device, class 2A. It is certified in lots of countries. It is translated in native language. And this software is available on the PC Windows, Mac OS, or mobile iOS. What that means? That means that you can download freely this software onto as many computers you want in your hospital or outside of your hospital and use it. The only price, the only cost is for the model. That means for the analysis. Exactly what you do in routine when you ask for a biological analysis. You only pay for the analysis, not for the readers that will allow you to read the result of this analysis. It is the same spirit. So what that brings? I think the best is to show you live demo. I don't like to do a video in advance. I prefer to do live demo to show how it works and why it's so great to use this system. Of course, we will work onto the lung. We will work onto the segmentectomy. It is a topic. You will see that it is possible to do this kind of thing for large set of pathology. I will essentially focus on 2 tumors, but it is not the only possibility, as you will see. So, first example with this patient who had a diagnosis of a solid tumor located in the segment 9 of the left lung. The planned resection was a left segmentectomy 9 in the left lung. Let's switch now to the software for the live demo. So here now you see my software, visible patient planning, onto my PC. My PC is a Surface Windows, so it's a small computer. Don't need necessarily a big one. You clearly see here the tumor located in this part of the lung. The first thing that the software can provide you is a colored image where you can see in green the tumor, in yellow the security margin. It's really important because during the previous presentation you hear teams that explain you that there is the problem of recurrence that arrived, and the recurrence is partially due to the fact that we don't necessarily can guarantee the security margin around the tumor. You see here that we can see the security margin. But this nice image, for me, is not a so nice image for a simple reason. It is a set of slices. And it is like if I show you a map with colored road, but it's not so nice than a real 3D image like this one. That is clearly better, as you can see. In this image, you see the upper lobe, the lower lobe of the left lung, and we clearly see the location of the tumors with the artery. I have the possibility to show and to remove as I want each structure, because as you can see here, I have the list of organs that is available, and I can add or remove any structure. For instance, I can remove, here you see the artery. You see here we have 3 branches, the segment 8 branches, segment 9 branches, segment 10 branches. We have here the segment 6 branches. And if I put a clip with my software, I will immediately see the territory associated to each branches. And it is really the main difference between visible patient solution and any other solution, because I can put this clip anywhere. What I mean, for instance, you want to clamp only this branch, I can do it. And I will see immediately the associated territory. I can do the same for the next one here. If I clamp the previous one, of course, you will have the join between the 2 things. And you can do that for any branches as you want, onto as many segments you want, as many branches you want. You see, so it's not only segmentectomy, it's also possibility of segmentectomy. In that case, you see that we have a tumor located here. If we look about the security margin again, you see that we have a part of the security margin that go outside of the territory, but it's a small part. It's the same for the 10th part. It is clearly located at the middle of the segment 9. It could be only a segmentectomy 9 as planned. what now, and it is a key issue as you will see, about the artery. If I had the arteries now, I will see that we have a joint artery, a common artery, for the segment 9 and 8, and not from the 10 and 9, which is the usual configuration. So that means that here it will be really hard to resect only the segment 9 without to cut this artery of the segment 8. You see, we will have a set of arteries. It's possible, of course, but it is much more complex than to cut here the artery of the segment 8. So perhaps it would be easier to resect together segment 8 here and segment 9. So here you see I have a right lateral view of my lung, allowing me to see here in a different position. What is really great with virtual reality is the fact that you can rotate in any direction. The body here in the lower part, you see, allow you to see the position of the patient to don't lose your landmark. So you see here the possibility to resect these two things. What about vein now? I will remove now, as you see, the arteries and only screening the vein. You see that we have a dedicated vein here for the segment 9, really easy to check, and we have a vein for the segment 8. When I rotate in a right lateral view, I will see that in reality, we have a common vein here for the 8 and 9, like for artery. So if I clamp here this vein, if I clamp in the same way the arteries we have seen just before, so I remove again the vein, just here, I can resect much more easily these two segments together in order to avoid any difficulties for the blood supply, and I will sure that the remaining lung will be totally safe because it will have the drainage and the vascularization that is totally efficient. So here is the first example of this possibility. You know that in routine, this kind of anatomical variation, anatomical specificity is really frequent. You will have frequently variation, but much more, I think, because it's what we have seen on liver, that for lung it's the same. Any patient is different. Any patient has his own anatomy, and it is the reason why it's so great to have a patient-specific anatomy in such a case. So here is for the first case. Let's check immediately a second example with this patient. It's a recurrent tumor, so we have speak about that just before. This patient had already 2 lobectomy. The first one was in 2016, the second one in 2017. And she come back in 2019 with the new tumors that you can see here in this image. She had a right lower lobe, a right upper lobe resection the first time, a right upper lobe resection the second time. And she has now a new tumor that appear. What to do? Of course, not a lobectomy. The only possibility is a segmentectomy, but is it possible or not? Here, what will be really interesting is the fact that in that example, you will see major variation in the anatomy due to the fact that the patient already had a lobectomy, the upper lobectomy. You see here, it's a ground glass tumor. It's not a solid tumor that appear, and the system, of course, can be efficient as well for ground glass tumors and for solid tumors. You see again here the colorization as I presented you that before. Again, what is the best is a 3D rendering. So let's check this anatomy now in detail. In the anatomical point of view first, perhaps. So again, I show you the list here of the organs. I'll remove arteries and vein to focus onto the bronchus tree. So you can really easily see here the segment 8, here the branch of the segment 9, and here the branch of the segment 10. So we have here the different branches. Sorry. Okay, segment 10, and you see between the two ones, segment 9. Okay, you see the shape is totally unusual. Why? Because we haven't got upper lobe. If you look the branches here, that is the branches of segment 6, we can see that really clearly, that this lung here has a location of the segment 6 that replace, of course, the usual location of the upper lobe. You have the middle lobe here, that is correct, with segment 4 and 5. 4 and 5 here, 4 and 5 here. And you have in the internal view, you see we have the segment 7. So here you have this patient-specific segmentectomy after upper lobectomy. Clearly here we see that the tumor is located in the segment 9. What will be really interesting in that case, as I will show you now, is the fact that we have, I forget to show you, yes, at point, it's interesting. We have the possibility to show the second lung because everything is computed from the two lungs. So, sorry, I come back. So you see here, these tumors located in the lower part. As you can see, it is in the segment 9, but we have two branches. And when we check the upper branches, you see, on the lower branches, we can see that we could perhaps expect a subsegmentectomy in the lower branches. What about arteries and vein now? If I had arteries, you can check that here we have two arteries coming from a common branch with the segment 10. This artery is clearly aligned with the lower branch that you can see here of the segment 9. The upper branch is here as his own artery in the upper part. So why not resect only these two branches together by resecting this lower part of the segment 9? Perhaps it's possible. We have to check in the same way, in this case, the veins. What about the vein? You can see here that we have a common vein for the upper part here. You see this upper part of the segment 9. We have a common vein with the branches here coming from the segment 10. So we have a common drainage for the upper part with the segment 10. For the lower part, you see that the drainage comes from these branches, and these branches are common branches of the segment 8, just near. So, of course, it's really important to see that in advance if you expect to resect only this part of the segment 9. You see, it is what was performed by the surgeon. She has resected this subsegment 9. It was possible, but of course, when you look at the shape of this subsegment 9, it looked like a normal segment 9. Don't forget that the patient already had a lobectomy before. So you see here again a possibility offered by the software with this 3D reconstruction, allowing you to see perfectly the anatomy, the patient-specific anatomy of the case. Feedback of the surgeon after the surgery was the following one. She writes us this letter. This intervention could not have been considered without that kind of reconstruction, and no other therapeutic project was contemplated for this patient. I'm happy to say you that the patient is always safe. She had absolutely no recurrent tumor signs this period of time. Of course, it's only one case. We cannot do a generalization of that, but it's an illustration of the possibility that is offered when you can have such 3D reconstruction for patient-specific surgery. So, I tell you that it can be applied for cancer, but also for other pathologies. So let's check some other pathologies where the segmentectomy or lobectomy can be useful, and the anatomical reconstruction is useful. It's a case where you have here, as you see, a double sequestration on left and on right, as you clearly see, in the lower part of each lung. It was the diagnosis. When I switch in 3D, you see the same patient. So now I can, as previously, remove the structures that are not useful for me. Here, the bones typically, and I will focus onto this different lobe and lungs. What I want to show you that is really interesting in that case is if I put without transparency the left lung. In such a case, you see that this part remain transparent. If now I put with transparency the left lung, but I remove the transparency of the right lung. In such a case, you will see that the left part here is not anymore transparent. What that means? Indeed, if you check, you will see that there is absolutely no link between this lower part here on the left with the lung, the left lung. That means that this sequestration is not a left lung sequestration. And if now I put again with transparency the lung, you will see that indeed veins come back to the right part. And so this part is a right lung part, and it is drained. There is a drainage from the right lung. We have also bronchus coming from the right. So you can easily see here an example of unusual anatomy and, of course, unusual pathology that create, without the model, a big trouble during the surgery. But thanks to the software, of course, everything was known in advance. You cannot have any trouble with that. Another example, because it's not only for adult but also for child, we can use that for any age. It's for this other case where you will see here not tumors, but an emphysema, a big emphysema. This case is really interesting because from the image, the radiological department said that this emphysema was located in the lower lobe, of course, the lower left lobe, and the surgeon was thinking that it could be onto the upper lobe. So he asked for a 3D reconstruction. Here is the 3D reconstruction of this child, really young child, baby, indeed. I will remove bones again. You see in 3D really well here the different structure. I will remove, as before, arteries and vein. So let's check. Yeah. Okay. Arteries and vein. And what I will discover now is the fact that in that case, we can recognize really easily the usual segment 1 and 2 and the segment 3. We can recognize the segment 4 and 5. We can recognize the segment 6, 7, 8, etc. But here we have an additional branch that appears here in the middle. And when I click onto this branch, it corresponds perfectly to the territory of this emphysema. If I check now the medical image with the colorization, you will see that indeed we have here the bronchus tree, classical bronchus tree with dark colors, dark gray levels due to the hair inside. But we have an additional tree that is not visible immediately with my eyes, that a computer can compute, and that appear in pink. And this additional tree is the bronchus system that you can see here inside this tree, that is the additional branch. So the surgeon resected this tree with the associated arteries. So you can see that there is a dedicated artery here. And so he has resected this branch. And with the associated vein, because it has also a dedicated vein, as you can see here. And by resecting this tree, he has performed a kind of lobectomy, but you understand it's an additional lobe that does not exist in a classical anatomy. But essentially, the patient, after the surgery, had his full lung with the upper lobe and the lower lobe, like if he has no problem finally. He had, during the surgery, the child was 6 months old. Now he has 2 years old. I can say you that he is perfectly safe. It's another example of the benefit of the system. So, I don't know if I have time for last example. Perhaps no. I will let for perhaps for question. What I want to say you is, of course, there is lots of publication about that different use of visible patient in routine. What is important to summarize? You have understood well that it is a wonderful tool to explain a patient anatomy. Of course, you can explain that to the patient, but essentially also to share in your surgical teams this information preoperatively or intraoperatively. Intraoperatively is what you can see here, where you can plug really easily your own computer, your own smartphone onto your OP room display. You can see here example of the use in our teams of that kind of things. You see here the video of a use where you see the tablet that is really easily managed, or you can also plug it with the robot, as you can see here. It's really easy to plug in the back of the robot. The surgeon look inside the video here. In the upper part, you can see the internal laparoscopic view, and just under, in the same view, he has these things. That means the tablet vision. He manipulates the tablet here, which is a classical iPad. It's not. You can do that also with your iPhone, with your PC, or with your Mac, and you see the view. In the upper view, the surgical view. In the lower view, you see the 3D view. So it's only a set of examples illustrating that you can use that not only preoperatively, but also intraoperatively. You understand really well that it is really the beginning of what we call the digital surgery. Thank you for your attention. So I'll let you the hand.
Very good. We are all back together, and we have some question in the chat. I think I would direct the first one to Luke. The question that comes through is about what protocols do you need for the CT scans to be able to generate this kind of imaging?
So you see, when we have started the project in 1999, my objective was to have a system that doesn't change my routine at all. So we have tried to do the same here. It is a classical CT scan with an arterial phase and a venous phase, allowing us to have a good vision of arteries and veins. That's all. Main issue, you mustn't have a too big slice thickness, because if you have a too big slice thickness, we cannot do such nice reconstruction of small vessels. But to be honest, in routine, nobody do big slice thickness. We ask for a maximum of 2 millimeters slice thickness. Today routine is much more 1.2, 1.5 millimeters, so there is absolutely no issue. So it's a classical CT scan performed like in routine you do that we need.
That's fantastic. There is a question that that is the difficult one, and is about, have we, has anyone demonstrated clinical benefit with the software? And again, you are the one with a better view on what research is going on. So Luc, again, if you don't mind, thank you.
So today, Professor Gosso, certainly you know him well, Dominique Gosso, used it in routine since several years. He has published several articles. It was on my slides, but if you want, I can go back on my slides. But he has published several articles illustrating the benefit of this kind of 3D reconstruction. It's not what I've seen just before presented by Tim, because Tim illustrated information about comparison with lobectomy. Today, there is no such comparison that has been performed. What has been performed is what you can see here, the fact that it simplified the segmentectomy. It's avoid error, essentially, because you know in advance what is specific position of arteries and veins, and it is really the main benefit you will have. I think that after what I've seen presented by Tim, what should be interesting should be to compare lobectomy with such segmentectomy using the security margin and the possibility to virtually clamp preoperatively and to select preoperatively your best trajectory. Because I'm sure that if you do that, you should obtain what we have obtained for liver. What I want to tell you for liver is the amazing result we have obtained, not only us, but all the team who have worked with it. In 1/3 of case, when you use the 3D model, you change your plan, and the plan is only validated intraoperatively and postoperatively. That means that it is a major change in some case, not always, of course, but in some case, it's a major change. I think that in the future, the segmentectomy that you practice when you are an expert will be increased in the number of cases because you have this kind of modeling. And secondly, we will have a new visualization of what is a surgery with what I call multi-subsegmentectomy, linked not to the bronchus only, but also to the arteries.
So, Gianluca,
I love to hear team experience or team insights, putting together the planning and the journey.
Yeah, so Gianluca, just coming back onto the sort of the evidence for it, or why we should be using it. And I've done a lot of segmentectomies, and certainly I've done a segmentectomy and then found that the tumor's not in it, and I've taken out the segment I wanted to and the tumor wasn't in it, and that's because I had misinterpreted the CT scan. And similarly, you start doing a segmentectomy and you end up with a venous anatomy that you weren't aware of, and you're not quite sure which bit is draining which segments. And so I think this is where visible patients is so strong, is firstly identifying accurately which segment or subsegment it's in, so that you know when you're starting that you're taking the right segment out, but also those little surprises that you come across during the operation with a variety in either bronchial or vascular anatomy. Those surprises are gone. You've made a plan right from the outset how you're going to manage this. And so I'm sure you've done it as well, Gianluca. You've started a segmentectomy and you've either not been able to find the tumor, or the tumor is not where you thought it was, or the bronchovascular anatomy is not what you thought it was, and you end up doing a lobectomy instead. And so the hope, the expectation, certainly the experience of people like Dominique Gosso is that you've set your stall out right from the beginning, and you know what you're going to achieve during the operation without any surprises. So that's where the real strength of this software lies.
Yeah, Tim, I agree. And again, in addition, there is the time in theater you're doing one of the lower lobe segmentectomies, and you find the vessels, and you start, is this one the one that I need to divide, or is actually the one that is like behind? Sometimes you find a vessel that you didn't notice on the scan, you go back on the scan. It is all time that the patient sits, lie on the table on single lung ventilation, and the procedure gets longer. So, that is interesting. There is an interesting question that is about when we deflate the lung, how does the anatomy changes? Now, my instinctive reply to it is the relative position of the structure, the one that normally approached, doesn't change much. But it would be nice to have maybe an insight from Luc that has a more direct experience with surgeons using it.
Indeed, of course, you are a thoracic surgeon. You know that when you deflate, the shape change. Of course, it's logic, but the topology don't change. And it is what we show essentially when you look branches, what surgeons do in practice, they count the branches, and so there is one bifurcation here, it is this one onto the 3D model. What is really important, perhaps it was fastly shown, but the fact that you can rotate in all directions. All the surgeons who use visible patient today use their smartphone intraoperatively, because intraoperatively they have the vision of the real patient in front of their eyes, and they put in 3D with their smartphone in the same position the branches. So it's like a GPS. You know exactly what is the road. You know if it is the first or the second on right or the first or second on left. The topology doesn't change, only the shape. And of course, when you have this topology under your eyes, it simplifies, of course, the surgery.
Yeah, and of course, Gianluca, it means that when you're doing the operation, you need to do a full dissection and expose everything around. If you do that, then you won't get lost.
That's really good, really good. And I think, in addition, is that technology is actually helping a lot. The visible patient is one of the technology that is coming through. There are ways of visualizing the vascularized segment theater. So the quality of the segmentectomy is also going to significantly increase, and that may put additional question marks on what is the value of trials that are really, really old. So the 1995 results, the segmentectomy done there may have been technically the same, but the information coming through available to the surgeon was significantly different. I think we're looking at a future that it is very different, and one of the challenges for the surgeon is going to be how to incorporate all this new technology available in theater in a way that streamlined the workflow. I think we had a really, really interesting hour, and we are more than happy to present the software in a more relaxed time with a little bit more interactivity if there is anyone on this meeting that is interested in it. And with this, I think we can probably close this call. And thank you to everyone who's woke up early and joined today. Thank you so much, everyone. We'll go to the next meeting. Thank you. Bye.
And do not hesitate to ask questions online. Bye.